Emergency Management of Appendicitis, a short tutorial for Discover Pediatric Surgery by Nirav Patel, Mali Murray, Ellen Mapunda and Hansraj Mangre. Appendicitis is one of the most common surgical emergencies in children. It is more common in boys and children over 10 years of age. About 7% of all children will develop appendicitis in their lifetime. The appendix is a blind-ending tubular structure arising from the cecum. When the lumen becomes blocked, bacterial overgrowth can result in appendiceal distension. This distension causes ischemia, ultimately leading to appendicitis. In children, this blockage can occur for many different reasons, but the most common cause is an appendicolith, lymphoid hyperplasia, or an intestinal parasite. Although classically identified through the constellation of periumbilical pain that localizes to the right lower quadrant, fever, and gastrointestinal symptoms such as loss of appetite, vomiting, or diarrhea, appendicitis in children can be much more subtle. Young children may only present with irritability or lethargy. Given the variable location of the appendix, children with appendicitis may present with pain in the right upper quadrant and even pain when passing urine or stool. Fever can be low-grade or absent. Constipation, acute gastroenteritis, mesenteric adenitis, urinary tract infection, and acute ovarian pathology can all mimic appendicitis. Those patients with migrating abdominal pain, loss of appetite, fever, nausea, vomiting, or diarrhea, and tenderness in the right lower quadrant should always be referred for specialist assessment. Always maintain a high index of suspicion for appendicitis, as missing the diagnosis can be devastating. Be patient when examining children with abdominal pain. Start by examining the patient's general state and looking for evidence of tachycardia, tachypnea, fever, dehydration, and pain. When performing a focused examination of the abdomen, look for distension before palpating. Always ask the child to point to the area of maximum pain and start your examination away from this point. If the child is anxious, try to distract them during the examination. Tenderness is usually elicited in the right lower quadrant over McBurney's point. You can look for other signs of appendicitis such as Robsing sign, where palpating the left lower quadrant causes pain in the right lower quadrant, or the obturator sign, where pain is elicited in the abdomen by internal rotation of a flexed right hip. If you're struggling to examine the patient, simply ask them to cough or jump up and down. If this worsens the pain, appendicitis is more likely. All children with suspected appendicitis should receive a urine dipstick. The urine analysis may reveal blood, protein, and leukocytes in the urine. In adolescent girls, a urine pregnancy test is appropriate. Ultrasound is a diagnostic tool of choice when the diagnosis is not obvious. Remember, you don't need a confirmed diagnosis to refer the patient. In those patients with a low index of suspicion for appendicitis, you can observe the patient followed by a repeat examination. Always make sure to take the time to counsel parents on danger signs or symptoms requiring reassessment. These include persistent or worsening pain, vomiting, diarrhea, loss of appetite, and fever. Delays to seeking and receiving care in appendicitis can be deadly. Act appropriately and early to avoid unnecessary and potentially life-threatening complications. If you suspect your patient has appendicitis, remember to keep them nil por us. Put up an IV line and give them appropriate resuscitation and maintenance fluids. Keep the child warm. Give analgesia. Give broad-spectrum antibiotics that cover gram-negatives and anaerobes. If necessary, place a nasogastric tube and leave it on free drainage and administer oxygen. Always counsel the parents on the possible diagnosis, what you're doing to manage the problem, and the potential need for referral to a specialist center. Remember to call your referral center early to arrange for prompt transfer. Thanks for listening. If you see a case like this, please share this video with your colleagues. All videos can be found on the Surgeons for Little Lives website or the Discover Pediatric Surgery YouTube page.